Yes.
Right. So we have officially got a new name for our Thursday sessions. And this is actually the last session of the year. We'll be taking a break for the summer and then beginning up again in the fall. And this is a special rounds with a focus on medical education research. And it's with great pleasure that I get to introduce today's presenters. First of all is Parisa Rezaiefar, who is a clinician in our Department of Family Medicine at the Bruyère Family Medicine Center. Her area of interest is using simulation to teach women's health office-based procedures. She's a recipient of the 2013 CFPC grant in women's health to develop further skills in women's health with a focus on conservative management of pelvic organ prolapse. She's a recipient of the 2015 DFM Research Grant Program for Innovation, or PRIME, to examine the use of simulation-based education in building capacity amongst academic family physicians. So I've had a pleasure of working with Parisa for a number of years. I can attest that she is a stellar educator. I've seen her in action with her residents. And today you're going to see her present not only her work, but also work that she's doing with residents and medical students. So presenting along with her is Dr. Janine Kay and also Tanzila Bazra. They'll be partaking in the presentation as well. So Parisa, welcome, and we look very forward to your presentation.
Thank you. Good morning, everyone.
Sorry.
So I feel like Doug and I have been through so much together. In fact, my children on Tuesday mornings, they say to me, "Is this Doug and Joe Day?" and it sure is. So now we've added Maddie to our team. So I think it's really important, as Doug always says to me, that, where do I point to get going? That recognize that research is really a team sport. And that's why I wanted to bring my team. One of our team members is in Toronto, so we couldn't bring her along. And as I said, two of our team members, Joe and Maddie, are here. So I couldn't do this without this wonderful team. So, and I have to say, that's a square, and I told my team that I should have taken a Ritalin because I move a lot usually, but unfortunately I don't have one. Okay, so essentially what I want to talk to you about is this research project that we've done over the last 2 years on kind of studying how better we can deliver procedural skills in women's health. This is an observational study and really looking at medical education and how better we can deliver that. Although I use pessary as my model of the teaching, you could apply this model to other procedures. So you could apply it to IUD insertion, endometrial biopsy, vulvar biopsy, anything else. So I want you, when you listen to it, don't get too focused on the actual procedure we were thinking, but our overall goal of how to deliver this skill in a better way. So I'm going to tell you a little bit about the background and the main objective, and then we will split this to phase 1 and phase 2. So phase 2, Janine will be focusing on it, but really I'm going to push through my phase because the most exciting part is this phase 2 and of course the conclusion and our future work, and that's why I need your feedback. So I would like you, when we get to phase 2 and the future study, to think about giving us feedback, because that's where the excitement comes. This research is almost wrapped up, we're almost finished, and we want to know, where do we take this next? We have no conflict of interest. As mentioned, this was a generous grant that we got from the department. It's wrapping up 2015 to 2017, and everything was approved thanks to Joe's hard work through BRI and Ottawa Hospital Research Institute. So why do I care about this study, and why do I think that you should be here listening to this? Because it has actually two significance. One is the clinical significance, which is important to me as a clinician, looking at a gap between what we need in the system and what as physicians we're delivering, and then the educational significance. Again, noticing there is a gap between the way we deliver the education to our learners and what we are actually offering them. And I think that's the excitement of this study, at least to me. So clinical significance for non-clinicians, warning, there are going to be some horrific pictures coming up, but essentially up to 50% of women will develop pelvic organ prolapse in their lifetime. And as we get older and our society is affected by an aging population, the demand for the service keeps growing. And waiting to see a urogynecologist, sometimes 3 to 6 months. Surgery is a solution, but it's extremely expensive, and it has many side effects, and failure rate is really high, up to 50%. So SOGC came up with this. SOGC is the Society of Obstetricians and Gynecologists of Canada, came with this recommendation and put pessary as the first line of treatment, conservative treatment for pelvic organ prolapse. And when you look at it, pessary fitting should be within the scope of practice of family physicians. But when I started looking around myself, there were very few family doctors who were providing that service to their patients. And more importantly, actually Chris Rive, who will be presenting after me, did a study at looking at the procedural skills that family medicine residents need to have to graduate, and pessary care is not one of these skills. Yet we have 50% of our female population that will be needing this. So that gap was really, for me, it was almost dumbfounding. Why is it that we're not pushing more? And mostly because we don't have teachers. We don't have physicians who can actually teach the next generation. So this is pelvic organ prolapse. So essentially, uterus, bladder, or part of the rectum are falling into the vagina, can cause a lot of discomfort for women. And this is a pessary, okay? So it's a very little device. It's been in history forever. You could actually search this on the internet and see the devices that through the history have been developed. And it's very simple. You just put it inside the vagina, and the woman feels really great, thank you. And all you need to do as a family doctor is know how to put it in, how to take it out, take a look at the vagina, and address side effects and manage complications. So it's definitely not rocket science. We do way harder things in family medicine. So that was the clinical significance. Let's go over educational significance. So when I wanted to do a simulation workshop, I wanted to understand what is my outcome. How am I going to measure that I'm effective with this teaching? Now, when you look at AMA definition of outcome measures, when you deliver a curriculum, there are 7 aspects to it, okay? The problem is that most workshops only look at their outcome by participation and satisfaction. So think about any workshop you've been to. They ask how many people participated, how popular it was, right? In fact, I got invited to go back to ASA because they said, your workshop was very popular. Okay, great. And then the second question is how satisfied were you, right? So these are the only 2 measures that most workshops look at. I wanted to take that a little step further. And so we started with Doug looking at, well, let's look at other outcomes. What about their learning? What did they learn? And were they able to take that learning and change their behavior, how they actually deliver that care that they've just learned? And then how did their performance change, both in reality and objectively measured? But most importantly, how did it affect patient health and ultimately population health? So our study really tried to tease out the outcome of our work when you look at these outcomes rather than just participation and satisfaction, which most traditional workshops do. So here's our setting. Bruyère and Primrose, our sister clinic. When I joined in 2013, and I had Doug as one of my teachers watching me teach and got tons of good feedback, By 2015, I realized there's something wrong here. We've got tons of competent family doctors who are doing a lot of good things, and yet when it comes to pessary, they just send them either to a urogynecologist or they send them to my clinic, which used to be called Women's Health Clinic. We still have it, so that I can do this care. And so I thought, no, everybody can do that. So decided, let's train everybody. So we did. So we recruited the faculty. Now it's important, the faculty is really important because I need them to model that to the residents. So this is my happy faculty. And we refer to them as main responsible provider when I talk about them as a clinician, or I talk about them as experienced clinician when I compare them with my postgrad residents, okay? So the second group of people who participated were my very enthusiastic family medicine residents or first-year residents, and we refer to them either as FM resident or postgraduate trainees. Okay, so again, the main objective was train them, get the pessary care out of the specialty clinic, give it to them in their regular clinic. Simple as that. So the first part, which is phase 1, we looked at training faculty and family medicine residents at the 2 sites, Bruyère and Primrose. And these are all pictures of pessaries for you to learn what they are. Okay, so our intervention was a simulation-based workshop. This is my wonderful graduated Kelly Force, who was a Women's Health Fellow, who helped me deliver this care, which was really, really tough. Because we essentially had to individually look at every practitioner, how they perform, and grade them. So she did an amazing job helping me with that. So we'll build a workshop according to SOGC guideline. Here's the timeline, how we did it. So we got everybody, am I in the square? Yes, I am. So we developed a confidence survey. I'll explain to you what it is in a minute. We got everybody to fill out a self-reported competence in a way, which we call confidence survey. And then we watched everybody perform cold a routine pessary care, okay, to see can they actually do it or not. Then we provided the workshop. Immediately after the workshop, we got them to fill out another confidence survey. And then again, we watched them all perform that again. And then we repeated the confidence survey at 3 months. And then for the experienced clinicians, the faculty, we finished the study at 1 year. And the postgraduate trainees, because they're not always in unit, we gave them an extra time. So they're actually graduating and they're right in the middle of completing their confidence survey. So we wanted to let them finish their study and see what happens. So what was the competence assessment? It was essentially an OSCE, an observational performance. So one of us, either me or Kelly, would be the standardized patient. We had a pelvic model, and we had a patient scenario that they would go through, and we scored them based on each item that we were expecting them to perform. And it was validated for content. The confidence survey was a 5-point Likert scale, and the participant, essentially it was the participants' reflection of how competent they think they are, how confident they are they can do it. And essentially, as I said, we wanted to know as primary outcome of this study, are they competent and are they confident after our workshop? All right, so this is our group. So we recruited 16 experienced clinicians, faculty, and 15 postgraduate. The baseline is very similar. We just had a few more male experienced clinicians, which is very interesting because our generation changing and we're getting more female in family medicine. And as you can see, in terms of the experience of the clinicians, we had 0 to 10 years, 10 to 20 years, and 20 years of being in practice, yet hardly anybody had much experience with providing routine pessary care. So in fact, it was a very plain level ground, both for faculty and for the postgraduate trainees. Okay, so this is looking at the overall confidence and competence of the group after the workshop. So as you can see on the top panel, which is the confidence, both experienced clinicians and postgraduate trainees had a significant improvement in their confidence after the workshop. And the same thing for the competence. They showed significant improvement in their competence. Now I want you to notice this. When you compare the post-grad and experienced clinicians for the same level of competence, people who are far there, they might not see 50% before the workshop, 80% after the workshop, the postgraduate trainees had a slightly better confidence compared to their experienced counterparts for the very same level of competence. And I want you to keep that in mind. Okay, so change in the confidence over time. So what happens with their confidence? Because everybody says, well, I go to all sorts of workshops. By the time I see the next patient that I can apply this, I've forgotten, right? Which is true. I mean, that's the reality of family medicine. We don't do things often enough. So we looked at their confidence of the faculty over time. And as you can see, right after the workshop, the confidence shot up, really good, 4 out of 5, that's pretty reasonable. We wanted to know what happens over time. So this is 3 months and 12 months. Okay, so they had a little bit of a dip, but when you compare them with what I call the sham pessary, so we put these pessaries in that we never taught them, we never told them anything, it was just a name that we put in. So when you compare them with these sham pessaries that we never taught them about them, they had a little bit of increase in their confidence on those pessaries that we never taught them, and they stayed actually pretty flat. So that's kind of like an internal quantification for us to actually compare with placebo, if we want to call it that. What about the postgraduate trainees? I'm still waiting. We only have 9. Latest I've heard from Joe that have responded to our confidence survey. I've flooded their email account time after time. We'll see how many we have. So I don't have that data yet. Okay, now the second part was this. So in the postgrad trainings, we've walked away from confidence. Even though we carry on doing the confidence survey, we're walking away from it and we're actually focusing on a competency-based curriculum, right? Because we're understanding, as I showed you, that postgrad confidence cannot be reliable on their competence, right? So I wanted to understand, what about the faculty? What's the difference between us and them? Why is it that in workshops, we are only assessed on our competence? How confident are you after this workshop that you're going to be able to put an IUD in this patient, right? So what's the difference? Is it just because of our general experience, our wisdom, that we're given this privilege that we go get a workshop and then we can go put an IUD in a patient? So I needed to understand that. So we decided to correlate their confidence and competence and see if there's a correlation between that, and is there a difference between the experienced clinician and postgraduate trainees on reliably talking about their own competence. And if this correlation changes, does it change when we give them knowledge consolidation? Okay, that was the secondary outcome of our study. Okay, so this panel shows you the experienced clinicians' correlation of confidence and competence. So competence and confidence. Before the workshop, there was no correlation. Some people felt overconfident, some people felt not confident at all, and so there was nothing at all. After the workshop, the correlation actually improved, as you can see, getting closer to that middle line, and it was actually statistically significant. However, when you look at the change in correlation before and after the workshop, that change was not statistically significant. What about the postgraduate trainees? So again, remember, they were too confident. There was no correlation at all before the workshop. And interesting enough, after the workshop, the correlation did not improve. In fact, they remained overconfident on their skills even after the workshop. So neither it improved in terms of significant change, and nor the change was statistically significant. I know it's hard to wrap your head around that, but essentially, I can't rely on my postgrads based on their confidence. Okay, so now we're going to talk about the phase 2, and Janine is going to come and explain that. This came out, these data, 14 minutes, perfect. This data came out only 2 days ago, Maddie. So she's going to explain that to you. And this is where we wanted to assess essentially the impact of the practice change on patient care.
Perfect. So our outcome for this one, we're looking at kind of 3 different areas. The first 2 we've kind of grouped together as our primary outcome, and the third one is kind of our secondary outcome for this. So we're looking at the competence of the MRP, and we used 4 different things to measure that, which I'll get into a little bit later. And then we looked at the increase in the routine pessary care, which is the RPC there, in the family practice clinics, so in the MRP clinics. And then we looked at an integration in RPC care, and what that means is that sometimes at a family practice clinic what happens is that you have a visit for one thing, but you end up dealing with 6 other things at the same time. So we were looking to see if there was, at a routine pessary visit, did we manage other problems at the same time, or did we just focus on the routine pessary care, which would have been what happened in the women's health clinic. So this is kind of our methods and our timeline a little bit. So we had 12 patients that were successfully transferred, and we looked 12 months before, 12 months after the transfer date, and the transfer dates were slightly different for each patient, so we didn't choose a specific time, we chose whatever their transfer date was, and we went 12 on either end. And then we looked at the competence or the quality of care that was provided both before and after for pessary visits in both the primary care setting and the women's health clinic setting. And then we also looked at the number of visits in the primary care clinic for RPC, and as well for just generally the number of visits they had to their physicians, as well as in the specialty clinics both before and after. So the competence, like I was describing before, there's 4 things that we looked at, and they gave them a score out of 4 for this. So if they performed a vaginal exam, if they asked about or discussed complications, if they documented and managed those complications, and then did they suggest an appropriate follow-up interval for the pessary care.
Oh, sorry.
So this is the competence assessment. This is looking at everyone, so women's health and MRP together in this graph. And so then the pre and post would be before and after the transfer. And the mean is at the top there of the graph here on the 2. And the blue bars are when there was a score of 3 out of 4, and the red bars are a score of 4 out of 4. There was no scores that were lower than 3 out of 4 for the competence. And you can see that there was a slight decrease. But then if you look at the post-intervention on the right-hand side of the screen, for the MRP, it was 3.77 was the mean, and then for the women's health clinic, actually post-intervention, it was 3.71, which is interesting. They're not the same physician, so we're not comparing them directly, but it's interesting that they're quite similar post-intervention, even though there was a decrease. It seems like the 2 clinics were quite similar regardless. So then this is looking at the visit types and whether we had a change in the number of visits with the MRPs or not. And in the blue, there's the number of visits with their physician, their main physician, which were just for a medical reason. So things like blood pressure, thyroid, routine physical exams, those sorts of things were counted as that. And then in the red, you see visits that were with routine pessary care with their MRP, and that could have included other treatments. So if they came for pessary and got their blood pressure managed, that counted as an RPC visit with additional care, which we'll get into in the next slide. And then in the green is the women's health clinic visits, and you can see that there was a decrease in the women's health clinic visits, and that was statistically significant. And the increase from the red bar, from the first to the second pre to post, is also a statistically significant finding for this. So then to look at the integration a little bit, we had a little bit of integration before, but very few visits before for the MRP. There was actually, I think, only one physician who had 1 visit before the transfer for RPC, and they did integrate the care with something else. But then afterwards, there was a significant increase in the number of visits to the MRP for RPC care, and the upper portion of the right-hand bar shows the number of visits, or the mean of visits, I believe, right, Randy? For integrated care. So that many had other things managed at the RPC visit. And most of those things were blood pressure, thyroid. Sometimes they did a periodic health exam at the same time. lots of times there is counseling provided for anxiety, depression, grief, those sorts of things managed, as well as this with this routine pessary care.
Great. So, so that's great. So why is that again important, right? Because if I can actually make sure that my patient can go and check her blood pressure and pessary cared for, in fact, we save the system one visit. And I think that's how it works, right? We're responsible for a panel of patients. And I think that's really important for us to be responsible for that panel of patients and provide the care over the health care of the whole system. Remember, we wanted to look at the patient care, but we also look at the population health. And that's where we want to understand that even if they increase their visit to the primary care, we're a per capita billing, which means it doesn't cost the ministry anything. Whereas if I send that patient to a specialty clinic, we're costing the system larger. And that's why we have to think about integrating care to the primary care. And that's the significance of teaching our family medicine residents to do it in their own clinic rather than sending these patients out, because a specialist bills the ministry 4 times what I can bill the ministry. And I think that's really population health and outcome that we were looking at. So, blah, blah, blah. The bottom line is that we increase people's confidence, we increase people's competence. We showed to the patients who were very nervous to change their provider. And I think that's really important. I would love to show that to the patients who agreed to change their provider. They were very nervous because they would see me at every visit for this, to go back to their family doctor. And in fact, we showed them they're just as good as me. I have nothing to give you more than them. And you're saving one more parking visit when you come to see me versus going to see your family doctor, and they renew their antidepressant, right? So we showed there was no difference. And we also showed that yes, our doctors are perfectly capable of providing this care to their patients. All right, what are our limitations? Small sample size, academic setting. We had highly motivated faculty and residents who embraced and were so supportive of me in this study. I really appreciated that. We were both investigators, workshop providers, evaluators. Well, there was a little bit of a problem there, right? Even though our survey was very well validated, there's a problem when I evaluate people that I've just given a workshop to. And then, of course, the accessibility to the women's healthcare support. So I was always there. If they needed help, I was there to go and help them take a pessary out and put it in. So this is not necessarily applicable to reality. But the bottom line is that we showed that a simulation-based workshop helps. It increased their confidence, and therefore they go out and they do it more, and therefore their performance gets better. What happens in reality? Why does it not work in reality? So in reality, you know, the last time I was giving women's health teaching at the Sim Center, expensive place. It is so expensive. All these gadgets, all these beautiful equipment. Within 5 minutes, this was what's happening. Okay, this is a generation who is highly stimulated all the time. I don't cut it for them. Okay, I can't just entertain them enough. They're on their phone, on their iPad, and then eventually they fall asleep or frustrated, leave the room. That's what's happening. And we need to learn how to educate them in a way that they remain engaged. But if we want to do that, it's expensive, it's resource intensive. We have to have 5, 6, 10 faculty. We have a huge group of family medicine residents. We can't deliver that. And then, of course, I boldly recommend let's do OSCE for every workshop. Adding that layer is going to add cost and complexity of delivery. So, as I say to my residents all the time, when there's a complex patient, extend the system, not yourself. So we have all sorts of things out there that we can deliver the teaching with, so that when they come to their workshop, I become only a facilitator. Okay, I do all the prep, prior to the workshop with lots of fun multimedia, and then when they come, all I do, I facilitate. Evidence-based, medical education, evidence to practice. Give them a roadmap, tell them what they need to learn, and plan the learning ahead of time in their own house with popcorn, multimedia, or game, right? And we'll show you that. And then deliver the information. That's when you come to the workshop. And then give them a second chance. Give them a workshop to take home with them so that 6 months from now, when they have to put that test row in, it's in their iPhone, they press the button, they see how it's done, and they go get it done. So that's what we want to do. This is where we want to take this project for any of the women's health procedures. So really, the solution is Tanzila.
Hi. So I may not be in view of the camera for too long, but essentially, as Parisa mentioned, what do we want to teach them? We want to teach them the components of routine pessary care, and we thought a solution could be a video. And so there is evidence to show that educational videos are just as effective as workshops, as seen by Garcia Rodriguez and numerous other people who've demonstrated that something like IUD insertion can be taught through a video as well. And so I did a leadership project with Dr. Rezaiefar, and we developed a 5-minute video on routine pessary care. Not yet. Yeah, the link.
So as she's doing that, the key to have a successful video is that it needs to be short, and it has to be focused and deliver only things that you want them to focus on. And it has to be non-commercial. Whatever that is out there is commercial, put out by these companies. So if we want as a university to use that, we should not use commercial promotion when we're giving these workshops.
So just a disclaimer, there may be some graphic images, but our original video goes from what you need for the routine pessary care to the review of care. But I will just show you a minute and a half if it allows me to. Okay.
So as she's working on that, I just want you actually to focus on what's happening, right? So we are in university.
Sorry.
Describe the procedure, answer questions.
Our technology is not up to the speed that our users, which are our medical students and residents, are demanding. That's the problem.
Describe the procedure, answer questions, and provide support as needed.
A little louder.
Perform appropriate hand hygiene and put on non-sterile gloves.
That's the loudest for here.
Examine the patient. Assess the vulvar skin. Ask the patient to perform a Valsalva maneuver to assess for any new stress urinary incontinence. Place a generous amount of lubricant on the index finger. Assess the fitting by ensuring that your index finger fits tightly between the pessary and the vaginal wall.
So as you can see, this is something that's not
Remove the
as easy to
pessary by
show
putting your index finger behind the
in
wall.
person or on a patient.
Twist
So these
and
models
ask the
help us
patient to
show
perform a
what it would look like
Valsalva
inside.
maneuver. To
And these
clean the
videos can
pessary,
also be retrieved
wash it
before
with
an
warm
appointment.
water
So
and
I split it up
with
between
soap
insertion
while
and removal.
examining
If you have a
the pessary
patient
for any
and you
defects.
quickly want to remove it, it's a minute video.
Dry
Just quickly
gently
look at
and set
it, take it
aside.
out, and you're done as a refresher.
Perform a speculum examination assessing the condition of the vaginal tissues. Watch out for any abrasions, erosions, or foul-smelling discharge by turning the speculums 360 degrees, ensuring that all walls of the vagina are well assessed. You may use a proctoscopy swab to move any prolapsed wall aside for better visualization of the vaginal wall and cervix.
And so that's the clip for our video. Now going back, the next part,
So we
is it a
just talked
PDF?
about
Yeah.
the video.
So we had the, so we basically, can I do this? Or do you want to go to the next one? Okay. So we did the video, and then we realized that for a learning module to be effective, you want to make it interactive as well. And how to do that? Well, we thought Prezi was our solution. Now, I hope this cooperates. I think these computers are not equipped for full Prezi, but what we have is...
So the reason why we choose Prezi is because it's kind of like a game, a video game essentially. So you could put all your didactic that I usually try to deliver in a workshop through the Prezi. It walks you through looking after different patients, the management plan that you think you want to have, and when you choose it, it explains to you whether you were right or wrong and for what reason.
So this is just a sample video. We're just in work. This is all in works right now. But essentially, I have different exam rooms. This is the Bruyère Family Health team. And if I click, for example, exam room 2, here's a question that we have. Every time you select an option, you get more information whether you're correct or not. And essentially, you can learn from each option. Something else that we can also provide are images. So, I mean, you have a patient who's coming in and you do the speculum exam. What does it look like? That, can someone tell me what the answer to that would be? What does that look like? Is it a normal exam, a mucosal erosion, infection? Can't tell. Okay, so this is why you need to do our module.
That's right.
And then you would know. So this is in fact an erosion. And so when the learner clicks it, it says that it's correct. Great.
So if you choose wrong answer,
we have pictures and additional images and information on what infection would look like and so on and so forth. So we're essentially putting case-based learning with our video clips in an interactive module that learners can use to essentially get more information. And it's quite interactive. If, you know, I've already gone through these cases and I don't want to do that anymore, I have a patient in front of me, I have a quick Prezi link, I can go in here, look at a ring pessary, for example, and like I've shown earlier, I have the 2 videos, so one for insertion and removal. I can quickly do a 1-minute video and take care of my patient and be done. And so that's kind of what we're working on, and we hope that that will be a better solution to carrying all these big equipment to all these workshops around the country. Instead of that, we can just provide videos.
So the reason why we're loading back, the reason why I want to do that, because remember how they fell asleep when I was trying to do the didactic? And remember, the most important way to recognize or to meet the needs of your learners is that you have to hit all needs. So some people are auditory, some people are more visual, and honestly, I think this new generation, they are so stimulated by so many different factors in their life that it's very hard to keep their attention more than 10 minutes with me only talking. And so they can get all the work done, and whatever their learning style is, in fact, their learning style is, their need is met, so that when they come to the workshop, they can really focus on the OSCE part of it. And actually, I see that even further with visual, the visual reality, or when at Christmas time, I was essentially using my brother-in-law's iPhone with a little camera on top of it, and I was scuba diving, right? And I thought, oh my gosh, I can get them to do pessary this way, right? So we do have to move on and be disruptive and find different ways of delivering the curriculum. Okay, now the part of learning. So they go and watch all this at home. Yeah, we're almost done. And when they come to the workshop, all that we're doing this simulation with the model. Everybody gets a model. Now, it's still resource expensive. So how are we going to do that? Remember, everybody has to get a review of what they learned, because we're adult learners. So if we get the first-year residents to be teachers to medical students and the second-year residents to be the teachers to the first years, the solution is there, right? So second-year residents can be the standardized patients with the pelvic model, and we've got all the competency skills that they can check mark and give them objective assessment through the workshop, and then provide them the feedback because they've been through the workshop, And then I'm only the facilitator. I only give them correction and provide them my wisdom. And then you give them the module to take home, and so that as their confidence dips or their competence dips, next time a patient comes in on their phone, they look at it and they're ready to go. So we're done. This is the opportunity for you to give us feedback, because what we want to do is, how are we going to convince the faculty to invest in us? Because that's the big issue, right? We rent this beautiful sim center and spend all this money, but we make them fall asleep. And in order for me to convince them that it works, I have to show them the evidence for it. The evidence is there, but it's very trim. As it was mentioned with IUD and with knee injection, they've shown that video modules are just as effective as me being there. But there's still a skepticism, because we think as teachers we're so valuable. It's our wisdom that counts. But really, we need to put all our resources together. And therefore, we want to see if this kind of delivery will change, again, behavior with our residents who are graduating, performing these. How are we going to measure that in reality? Can we do chart audit? Can we look at their billing number? Say for IUD, endometrial biopsy, there's specific billing code that we can look as whether or not increased, or the referral pattern. Did they decrease their referral to gynecologists, etc.? And that's where we need some enthusiastic researchers to help us, because we only come up with the idea, and all the hard work is actually done by Maddie's and Joe's of this world. And there's my acknowledgement, and we're ready for questions. Are we in time?
That's perfect.
All right.
So we've got 10 minutes for questions and discussion. Do we have actually someone online? Can we start? Is there anyone online? There's no question online. Do you want to facilitate the discussion?
Sure.
You're good.
Parisa, did you, you mentioned avoided referrals
Yeah,
for this, and
yeah.
so,
We showed that, right?
right, and did you cost those out? Like, in
No.
order to convince people that this is valuable, you say, well, this is money that's
Absolutely.
being saved,
That's
and
correct.
that's going to be, that
And
would be
that's the key, Jacques, right? I think that's really important. So in our system, as I said, when they send me a referral to me, I bill the ministry at A905 out of the basket. Okay, but my follow-ups are still within our per capita, so it costs nothing. But think about, because I'm part of the group. But if I wasn't, so when I get referrals from outside, right? Again, this is extra cost to the system. But absolutely, if I go to small practices and I show that the referral pattern changes and they're not referring, so it was hard for us to measure costs. But we certainly, and especially because we had an increased number of visits, partly because there's a learning curve for the physicians to learning. So it's a bit different, but even with that, the cost would be less than them going to urogynecology. Because remember, Ottawa hospital parking, right? How expensive it is to the patient pocket, and then taking time off work to actually go to these visits. They sit there for 3 hours. I did my training there, so I know how long it takes. 3 hours for a patient to be seen. So it's half an hour of their workday that is gone, productivity to the system, and then the urogyne cost or the hospital cost, right? So it's no-brainer, but absolutely, if we have big number, we can show that. Yeah.
You also have patient days of discomfort,
Mm-hmm.
right? Like if it takes you a month to see the specialist, that's another
Correct.
month your patient is suffering.
Absolutely.
So
Absolutely.
that's,
right?
you know, and I think a very valuable outcome. I agree with all the cost stuff too.
Right.
You know, there's a
Absolutely, patient. And in
Yeah,
fact, that's
that's-
patient-centered, right? So my residents now are learning. I tell them, she says I'm incontinent, examine her, like
Yeah.
finish it, right? Today. Because again, we're per capita. It doesn't matter if you bring her back. Your job is to complete this task today. Absolutely.
I had a question about the confidence survey.
Yeah.
Was it given immediately following the workshop?
Yes.
So I'm just thinking, you had mentioned in the presentation that, you know, some of the overconfidence potentially of the residents might be because, that the medical doctors, they're not, haven't learned it right away, so that's why potentially there's not this confidence, in terms, so I'm just thinking if it had been given in a delayed period, or if you measure it more than once.
Well, we did, right? 3 months and 1 year.
Okay.
Yeah, so immediately before, immediately after, 3 months and 12 months. That's right. And we did show that they dipped a little,
Right.
but then they stay still about what it should be. Yes.
Iman. yes.
Iman.
Question from Dr. Diane Dalva.
Yeah.
Thank you, Parisa. Wonderful presentation. How much time and effort goes into developing the Prezi tool?
Not a whole lot, right?
I don't know.
It's medical student time, Diane. It's not mine. That's right. Well, no,
It's not too bad.
This whole presentation was actually a Prezi presentation because again, I wanted to be disruptive and show you how fun it looks when you're going through Prezi. It was fun to produce it, and we had fun developing it. So it's true, it's labor intensive, but once it's done, modifying it, upkeep of it is very easy, very easy. So this whole thing took us a day and a half of my time really, but I learned tons. So there's a learning curve.
And I think the other important thing is if you compare the time required to make that versus run workshops, you're saving an immense amount of time. I mean,
Well, because it's teacher
yeah.
time, right?
Yeah.
It's teacher time.
So you have one Prezi, once it's done, it's available to everyone and anyone who needs it. So I think it's worth it. And it doesn't take that long, as she said.
That's correct.
And how about the costs of Prezi?
It's
So
free.
this is the free Prezi.
Yeah.
So we're showing you free, and the only way I could actually get you a PDF, I had to pay $15. So if you get the fanciest one, so I'll just, this is really important. The fanciest model, which is like $20 a month, allows you to actually do data analysis. So you do your pre-workshop evaluation. So you collect all your data on their competence, on the didactic, and then post-workshop, you get them to run through it. And it's so easy, you could kind of mix and match and make it more difficult, etc. And then you get your data analysis. So in fact, you could grade your resident or medical students. So it's totally worthwhile at a university. Not that I'm not promoting anything commercial, but it is not that expensive when you look at the physician costs.
Okay, so I'm not very familiar with Prezi, so you
Yeah.
have the opportunity to embed the quizzes you have, so
Yes.
it collects the responses and
That's correct. That's correct.
And any other features like discussion boards.
Yeah, that's right. So
Things like
actually they have a feature, I think it's called, I can't remember, sorry, this is all new to us. And probably the best thing is to put another medical student to it because they're so much better than me. But essentially they have this module where you become the prof and the students can have a forum for discussions. Yeah. Oh, Doug?
Just a couple of things. Tanzila and Janine and Parisa, thank you very much. That was a great presentation. I first of all want to say that Parisa presented this at the Meredith Marks Research Day, which is our faculty's medical education research day. And she won the best poster presentation. So congratulations
Thank you.
on that. And I think one of the reasons for that is because you've done a number of things here. In your project, you brought in residents and medical
That's
students
correct.
to do this with you.
Yeah.
And I think that's extremely powerful, and it sets an exemplar for other activities.
Mm-hmm.
Another thing is that you have done something that's very confirmatory in the self-assessment literature. And that is that novice learners tend to overestimate their confidence. They tend to think that they're more competent than they really are. Whereas experienced learners, right, it goes to show that the more you know, the more you don't, and you tend to underestimate your competence. And
Absolutely.
This exemplifies that very well, so that's terrific. And the other part is the funding that you had for this was for the first piece, this part that Tanzila presented on the videos.
We've done it on our own time.
Correct. But this is the whole idea,
Of
right?
course.
Because you have this, you have this innovation, you try it out and realize, okay, this is going to be very expensive, and to take it from simulated center into practice is going to be very expensive. What are some other ways of doing it? So you're exemplifying here a movement in the whole university, which is moving towards a blended learning program.
That's correct.
Not just putting lectures online, but actually having them to be active.
That's right.
And then the whole movement here is, I think, 20% of courses in the university need to move towards this model by 2020. That's sort of the goal here. So you've given another exemplary presentation on how to do that. So it should be commended. Now, the one question I had.
Right. After all the compliments,
really
thanks, Doug.
With you had for your residents, you had 10 male and only 6 female.
Yeah.
But that doesn't reflect,
Right.
our population.
Absolutely.
Any insight into why?
So it's the opposite. Sorry, male. We had more male
Yeah,
for
more
the
male
faculty,
for faculty,
and more female in the residence. Absolutely, and I think that's the other thing that is really important to recognize is that every time I walk into a classroom or to a session, I look around to see how many female and how many male we have, because these are conditions of women, and traditionally women expect their care when it comes to anything below their belly button to be delivered by female providers, and that actually is leaving a lot of male residents behind in terms of their learning. So again, if I can deliver this module to them online, then they have this air of, again, confidence and comfort, so that when they come in to see a female patient, they're not so hesitant and resistant to be examined. So I think we have to watch both group of people, even though we have more female that are increasing in our care.
Just another suggestion that for your first question about how you can convince people, so
Yeah.
the economic side.
Yes.
There's also, in the whole province now is reorganizing, and each LIN is developing into sub-regions.
Yes.
And the whole idea is to integrate care. And
Yeah.
one of the top priorities is access to
Yes.
the family physician and to specialists.
Correct.
So if you can demonstrate the number of visits that you make available for the specialist.
Well, we just did.
That's right. So that's another important point
Yes.
for potential funders.
So Jacques, would you promote me then?
Well, I
because
think-
we can take our workshop into all fits in the region and teach them how to do it, and then we can show it, because our numbers are very small, but we need funding to actually deliver that.
You might want to come to our next Lynn CTLC.
Send me an email. I'm going to put it right. I'm going to put it right in my
And
calendar.
I can try and make sure there is a women's health sector
Initiative.
at the
Okay.
Lynn. So I'll find out about that.
Fantastic. Thank you. Yes.
Second question by Dr. Diane Delva. Is it possible if the department has an account, could all faculty members use it?
I don't know. I don't know. I'm sure we could strike a deal with them, right? Especially if they feel that we're going to be promoting that. Or we could use the same password.
Yeah.
As we've done, Diane, otherwise, we
I don't
just
think it's
use
a
the same
tremendous cost
password.
anyway.
Yeah.
I don't think it's a tremendous
No.
cost. So we need to take a break. We're going to take
Thank
a break until 9:35. Thank you, Parisa, very much. This was, I don't think any of us researchers, we have to learn from how Parisa delivered this, honestly. It was really well thought out and very well done. Thank you, Parisa and the group. So we're going to take a 10-minute break.